I'd like to present Dr. Louis Catalano. He's clinical professor in the Department of Orthopedics and Division of Hand Surgery here at NYU, and he's the director of the Hand Surgery Fellowship here at NYU as well. He's going to be talking to us about a often overlooked topic, I think, but is just as important as the surgical procedures that we do, and that's elbow therapy and splinting, what every hand surgeon should know. So take it away, Lou.
Thanks, Omri. So I'm going to talk about splinting and then instability and the treatment rehab of that. So the bare minimum of elbow motion is 105 degrees of flexion and 40 degrees loss of extension. I think if you have less than that, surgery is probably indicated. It's really important not to improve extension at the expense of flexion. Essentially, flexion is a lot more difficult to compensate for. People who lose elbow flexion have trouble shaving, putting their earrings in, reaching behind their back to do their hair. And the only thing you can do is flex your neck, which then gives you neck pain. In contrast, extension loss is pretty well compensated for by knee, hip, and trunk flexion, or you just walk a little closer to the object you're reaching for. So that's pretty easy to deal with. It's flexion loss that's really troublesome for activities of daily living. On examination, you want to check for two things, crepitus and tenderness. Just like wrist and hand examinations, focal tenderness at the elbow is really important. You want to differentiate radiocapitellar joint from lateral epicondyle tenderness. So you really need to know your surface anatomy. Crepitus indicates either a loose body, a joint incongruity, or synovitis within the joint. This is one of the few joints that I use a goniometer for. I think it's really important to measure, especially if you're going to do a release of the elbow, to measure accurately both active and passive range of motion with a goniometer, and make sure you reference it throughout the perioperative period. Pains at extreme flexion extension mean that you have impinging osteophytes, either from the olecranon or the coronoid. Pain and crepitus within the mid-ranges of motion means you either have arthritis, synovitis, or a loose body in the joint. And that's important to differentiate because that helps you determine what kind of surgery you're going to do. The initial treatment of any elbow injury or surgery is, as you can imagine, ice, elevation, and compression. As soon as possible, you want to start motion, essentially. Regarding CPM, some people advocate it. I've had issues with, number one, getting insurance authorization. Number two, proper fitting. It always seems it's either too big or too small for the person's elbow. And if you fit them pre-op, then their elbow's a little swollen and the bandage makes it too tight post-op. And then there's the data. There's pretty good studies to show it doesn't make a difference if you use CPM or not. So I've recently not used CPM. I know some of the previous panelists showed pictures of the static extension splint. I think it was Dr. Paxima. I love this for a big elbow surgery or a total elbow. I splint them in extension for 2 to 5 days. You can hang them up so they don't get swollen, and it really helps the wound healing as well. So regarding motion restoration, you want to start active and gentle passive range of motion as soon as possible. A little local heat helps stretching, but you have to tell the therapist to avoid forceful passive stretching. Too forceful can increase pain and swelling and cause additional trauma and may lead to heterotopic ossification. And we've seen a bunch of x-rays of that already. The therapists know this, but it's important to let the patient know that when you're stretching out, you should count to 10, and the pain level should be about 4 to 5 out of 10. So once you reach 4 to 5 out of 10, you want to hold that stretch and count to 10. And the idea behind this is stress relaxation, which means lengthening of the tissues subjected to a load below the elastic limit. Regarding splinting, this is kind of standard for many hinge joints, but the splints have to be carefully fitted in place by trained physical and occupational therapists. And if not, you may do more damage than good. Static splinting is helpful to maintain motion achieved during the day and during physical therapy. And static extension splinting can be used mainly at night if they're developing a flexion contracture. It's important not to limit flexion with a splint though. They're so-called dynamic splinting. Static progressive splinting or turnbuckle splints. This is the kind of a classic picture. This is best used for flexion contractures of greater than 40 or less than 40 degrees. And essentially, a static progressive splint uses some kind of ratchet or screw to increase the stress across the elbow. Here's one made by our physical therapist here for a lady with a terrible triad. This is basically a custom-made static progressive extension splint. Here's a recent patient who had a pretty bad distal humerus fracture. This is her kind of off-the-shelf or JOS splint, static progressive splint. And here she is using it the other day.
Twist it this way. Actually, this is as far as it goes in this setting.
She's turning that dial to get more flexion. Here she is turning it to get extension. We're using it for flexion, but that's what she was doing to gain more flexion as well. Dynamic splints require spring tension or rubber bands to apply a constant force to stretch that joint. It's best used for recent contractures with soft endpoints. The problem is it hurts. Imagine someone yanking on your elbow for 10 minutes. It's poorly tolerated. They can use it for about 10 minutes an hour. Obviously, they can't use it at night, but it's definitely effective for recent contractures with soft endpoints. The physical therapy program usually lasts 3 months, and I give people about 6 months of home therapy. And then at that point, usually active motion equals the hard passive endpoint. And when you reach that hard passive endpoint, you're really not going to make much more progress, as that hard endpoint represents non-compliant tissue that's not really going to stretch out anymore. At that point, once it's hard and the passive and active are the same, you really need to either talk about surgery or just living with that degree of motion loss. So the previous splinting protocol is used for any hinge joint, your PIP joint or your knee. But the real issue with the elbow is, how do you rehab an elbow that's unstable or has been unstable, and you fix the ligaments, try to make it stable? And that's the real, I think, the real quandary of elbow therapy. And someone touched on this earlier, but varus stress is the problem. So varus stress taxes the lateral collateral ligaments, and anytime you lift your arm, meaning you open your armpit, you're stressing your lateral collateral ligaments. If you're heavy or you have big breasts, that tissue causes varus stress to the elbow. And usually that's not an issue, but when your elbow is unstable or you've recently done an LUCL reconstruction, that's a problem. So protecting varus is sometimes tough, and if not impossible to protect against. We mentioned that residual instability is very difficult to fix. And essentially, this is my most biggest fear after fracture dislocations of any joint, really, is the LUCL, the elbow, making sure you keep that elbow reduced. And there are some really important points here that we're going to cover. So the biggest pearl is supine overhead range of motion. And essentially, you lay them supine and the elbow is moved overhead. And this is the best way to treat instability and get them moving soon. And it's used for either fracture dislocations or terrible triad injuries. You're using, and I'm going to show you videos of this, but you're using active muscle forces, mainly the triceps, but some biceps. And those two muscles contribute to dynamic stability of the elbow, while the compressive forces from gravity help stabilize the elbow as well. I work with 1 or 2 physical therapists and hand therapists specifically with these elbow injuries, because this is really tricky therapy. And if they're not careful and the patient doesn't do what they're told, they can stretch out their repair and render their elbow unstable again. So here's a case that was done in August. This is a lady who fell and had a terrible triad injury. We've seen pictures of this already. So she, as you can see, she's got a coronoid fracture. She has a radial head fracture. Here's a radial head. Here's her coronoid. And you can see her elbow is wide there. So this is a lateral approach. And it was mentioned that you can see this is the barrier. The lateral ligaments and the extensor mechanism rip right off of the lateral epicondyle. That's a pretty classic finding from a terrible triad injury. So I basically remove the radial head. You can see here's the radial neck here. Here's my flat radial neck cut. I like to fix coronoid fractures, so I put some sutures in these little pieces and brought them out through a drill hole. So here I am shuttling the suture through to the dorsal ulna. Then I replace the radial head. You do not tie those sutures until the end, by the way. You can see it's still a little gapped, so the elbow is obviously still unstable. I haven't fixed the lateral ligaments. Um, I believe strongly that you should use drill holes in the lateral column. So I use number 5 fiber wire in running lock fashion. I use 2 of them, and one is through the anconeus, and the other one's to the ECU and EDC. Dr. Verk mentioned that you really need to grab thick tissue because the ligaments lie on the inside of the tendon. So you need to grab the ligaments and the tendon. So your bites need to be full thickness with your suture. And then, as O'Driscoll taught us, you make a big drill hole in the lateral condyle isometric point. You drill usually with a 3-5 drill bit, and then I use a 2-5 drill bit out the front to the front of the anterior column, and then a 2-5 drill bit to the back of the posterior column. And then I bring the 2 strands anteriorly, the 2 anterior strands anteriorly, the 2 posterior strands posteriorly, and then I tie. Again, I like to tie just like Dr. Verk does, in some flexion and some varus stress, actually valgus stress. So here's the elbow post-op. You can see it's reduced. There's no more gapping. One mistake that a lot of people make, and I've done it, is you think, all right, this elbow's loose. I'm really concerned about the lateral ligaments. I'm going to put a big, heavy, long arm cast on to try to protect that joint as best I can. The problem is that's the worst thing you can do. And the reason being is the heavy plaster on the forearm pulls the forearm away from the elbow joints. In other words, you're stretching out your ligament repair with that heavy plaster cast. So it's counterintuitive, but you need the lightest thing you can. And the lightest thing you can put on the operating room is about 10 slabs of fiberglass. So I use a long arm splint of fiberglass in about 110 degrees of flexion and some pronation. And that's the best thing you can do intraoperatively. To rehab these, Aviva Wolf and Dr. Hotchkiss wrote kind of the seminal article on how to do this. Essentially, they talked about the importance of early protected varus eliminated therapy to help range of motion and bathe the articular surfaces with synovial fluid. And the key is to avoid that varus stress. So you cannot bring the arm, you can't abduct it. When you're upright and you're heavy, you have varus stress. So by being supine and with gravity, you can really get the motion going. And here's how you do this. So as soon as the patient can do this, usually post-op day 3, I have them go to OT and they get a custom-made long arm splint. You can see it here. It's in about 110 degrees of flexion or so, pronation. The wrist is included to rest the forearm. And this is very light. So by being so light, you're not dragging the forearm away from the elbow and pulling on your ligament repair. And essentially, elbow flexion and pronation is the most stable position after the elbow's been unstable. And then you have them start OT. So they start therapy with this overhead supine protocol. This position is easier at first because it's easier for the patient to move their elbow up and down. And I'm going to show you what that means. So here's a video. Now this is a little bit later on this lady, but here's the best position to do this initially. So she's using her left arm to extend and help flex her arm. Her triceps is firing to help stabilize the elbow, and gravity and her bicep are helping flex it down. So it's been shown you can cut out the lateral and medial ligaments of the elbow and do this and the elbow doesn't dislocate. So she's doing flexion extension. Here she is doing pronosupination. So they do this initially just because it's easier for their left arm to help their right arm. When they progress, you can see here she is about 10 days post-op. She's got the steri-strips on. You can do it this way, and I think this way makes more sense. They're supine. The arm is adducted, so there's the elbow, the armpit's closed. The shoulder cannot be internally rotated, and the arm cannot be abducted because that adds varus stress to the elbow. And you can't have that. So in other words, the elbow is straight in line with the side of their body. And they start bending the elbow, flexing it up and down as she's doing here. You can see she is, say 2 weeks, 10 days out, and she's already got great flexion. And that's gravity and biceps. And then her triceps is pushing her, and she's already got pretty good extension for a terrible triad at 10 to 14 days. You can see how she's pronated. Remember, pronation makes the lateral side of the elbow tighter and hence more stable. That's why the splint and her exercises are done in pronation. Again, you can see her shoulders adducted. She cannot bring her arm up away from her body. I tell the patients, don't open your armpit. When you're opening your armpit, you're adding varus stress to your elbow, and you cannot do that. So around 6 weeks, when the ligaments are healing, now you can start doing a little bit more aggressive things. So here she is. She's forcibly extending her elbow with a bump to try to get more extension. Again, she's in pronation here to help stabilize her elbow. And again, that's pretty darn good flexion and extension. Last thing you can do is use a bump to work on terminal extension. Remember, the elbow is most unstable in extensions. You probably don't want to start doing these strenuous terminal extension exercises for about 2 months until the ligaments are really healed. So thanks. I have some questions for the panel that I thought I was going to ask because I don't know the answer to these, and hopefully the panelists can help me. I was wondering if anybody uses oral steroids or intra-articular steroid injections to help the elbow loosen up. And then I had a question about, does anybody ever use manipulation under anesthesia like we do with the knee after significant elbow trauma? And last, what about hinged elbow braces for instability? My answer to that is, I don't think you should use them. I think you need to use the static splint that's about 110 degrees of flexion and pronation, as I showed you here. So Omri, do you care to take a stab at the top 2 questions here?
Sure. I mean, I think I'm not opposed to using an intraoperative dose of dexamethasone to prevent contracture. However, I'm more focused on if I'm really concerned about it, I would be more likely to use a dose of radiation after surgery. I think that the data about indomethacin is not super conclusive. Dr. Paxima, what do you think?
Yeah, I agree. You know, I'm always tempted to use the steroids, as Lou's brought it up a couple of times. I have not done it. I do use radiation. So typically, if I have someone who I'm concerned about, if I'm taking out HO, I'll book them for the HO and I'll book them for the HO for the radiation the very next day. So I used to have to keep them overnight, but now you don't have to do that. You can do the HO as an outpatient, and they can get the radiation the next day as an outpatient.
I would add that the oral steroids, I think, have been shown by the guys at Duke to be very effective for terrible triad injuries. So like the lady that I just showed you, I gave her IV Decadron intra-op and then a 6-day steroid Nedrol dose pack post-op. And that was shown at Duke to be significantly improve range of motion after surgery.
Yeah. So that's for an acute injury, not for HO prevention, of course.
Right. I'm wondering, at a month later, does anybody ever give them steroids or a shot into the joint? I've never done that.
I haven't either.
It's funny that you say that because I just did that today for the first time. So check in with me in a couple of weeks and I'll give you my NF1.
Elbow stiffness?
Yeah, elbow stiffness at a month or 6 weeks after surgery.
Right, it makes sense. I just never hear anybody doing it.
Mm-hmm.
Same thing with a manipulation under anesthesia. I mean, we do that for lots of joints, but I've never heard of anybody doing that for the elbow.
I've done that for the elbow. I just did it recently too on a case. This lady who had a distal radius fracture and a ipsilateral elbow dislocation, and ended up with a really stiff elbow at 6 weeks, and perfect skeletal architecture, but a super stiff elbow. And so I ended up taking her to OR because she had been fixed somewhere else. One of the screws was a little long on the radius. I had to take it out. So when she got the block, I did a manip under anesthesia and just got her whole range of motion back. So that was really, really encouraging. But I think manipulation under anesthesia has some limited role in the elbow as well.
Yeah.
Go ahead.
Yeah. So for me, for manipulation, post-traumatic, if within first 6 months, I think is the time after trauma where manipulation is going to work, because you are basically addressing intra-articular adhesions. Obviously, extra-articular adhesions are also benefited, but that's where you get that cracking noise and complete restoration of range of motion. So I'll make sure if I'm taking an implant, I'll do it prior, the manipulation goes first, then I'll take the implant out. And most of the times, if not most of the times, if I've ever had to do it, it was for an olecranon fracture. And I think around 4 months when the fracture was healed, I did manipulation and patient regained around 80% of the motion. And I took the plate out at that time.
So piggybacking off of that, we sometimes talk about the role of radial head excision in elbow stiffness and HO. And so, I'll ask you guys, what role does radial head excision play in the treatment of elbow stiffness and HO in your minds, and how to think about which patient is the correct patient for radial head excision?
Yeah, I don't hesitate to do that if there's PREJ involvement, and I think that helps a lot. Now, you've got to be careful in. I try not to just do a radial head excision in acute trauma cases because I'm worried about Essex Lopresti lesions, but it's unusual to get a elbow instability after HO release, but you can get it. So I've done it in the cases like I showed where there was a significant loss of rotation, and unless it was a synostosis case where you could really get all this stuff out, then I think the radial head excision adds something to it.
I would be careful to excise a radial head for a severe post-traumatic injury, even if it were a year or two later. I would put a radial head implant in if I took it out.
Yeah.
How about that?
You know, my
2 years later, someone developed Essex Lopresti lesion after.
Yeah. I would stick it back in.
That's why if I'm excising it, I'll probably replace it.
So for me, if the elbow is stiff, which means that there is a capsular contracture, there's a ligamentous contracture, the chances of that elbow becoming unstable will happen only if the medial and lateral column ligaments are completely transected. If the bony anatomy is intact, I try to shy away unless there's a deformity. In an acute situation, the things are different. In majority of the elbow dislocations, we know that bearing few cases, the MUCL is torn. The LUCL may or may not be torn. So doing a radial head, if the radial head is comminuted, not replacing, probably not a good idea. Not a good idea if there's an Essex Lopresti lesion, but I think I have very limited indications to take the radial head in a stiff elbow unless it's arthritic or deformed, or like Dr. Pexima said, the DRUJ range of motion, sorry, not the DRUJ, but the proximal forearm rotation is an issue. That's when I will take it, but not replace at that time because it even makes them more stiff in my hands.
Shifting gears a little bit, a little along the lines of instability, but treating patients with global ligamentous laxity, elsewhere in the body, obviously the shoulder and even the hand and the wrist. Have you guys had any experience with ligamentously lax patients with frank instability of the elbow, and how do you approach those patients differently?
Rehab in my mind.
And if rehab fails, again, rehab. So these are very unusual situations, and I think any kind of surgery, just like a multi-directional, is only gonna make things worse, in my mind.
Okay, and I actually have a question for Dr. Hochbord as well about you talked about the nutritional workup and pre-albumin in patients, and so how does that look in your practice? Are you referring a patient to a nutritionist? Are you delaying surgery because of malnutrition? How does that look in your practice?
So the majority of the time, these patients are already inpatient. So if a patient were to come as an outpatient with a wound, a pretty sizable wound that needs coverage, then of course, yeah, you do that workup as an outpatient, and if they have very poor nutrition, get them a nutrition consult. But typically, like I said, they're typically inpatients, and so you can get an inpatient nutrition consult. Insurers have family bring them food from home, have a high protein, high fat diet. And the other thing is minimize hospitalization. The more time a patient spends in the hospital, the more time they go to the operating room, the more decompensated they become. So it's really important to get the patients in and out quickly, get them treated, don't have them sitting around, because as we all know, when you're in the hospital, you don't move, you don't generate appetite, the food is bad, you get constipated, but you're not moving around, you're nauseated because of the medication and because you're constipated. So all those factors accumulate.
Understood. So now I understand you had a role in improving our hospital cafeteria over the past couple of years.
You know,
Seems like
actually, so we had a patient during the peak of COVID, and he had a wound, and we did a flap, and you told him, like, you need to eat well, but you wouldn't believe it, the hospital wouldn't allow family to bring in food from the outside. So here's a patient that did not like the hospital food. He needed high protein, high fat, and they would not allow family to bring in the food that he wanted. And so I'm thinking, like, wow, we're really shooting ourselves in the foot here.
Omri, have we touched on what people use, if anything, for HO prophylaxis after acute distal humerus fractures? I mean, when do people use it? Do they use it all the time? If they do, what medicines do they use?
So I don't use any radiation after a humerus fracture because, there's a higher non-union rate. And there was a study that basically had to stop that treatment in the middle because of the high non-union rate. So I think, someone else asked the question earlier too, how do you prevent HO? Typically who gets it is people who have had multiple manipulations. So it's the person who had a couple of reductions and they keep redislocating, or they've had screws placed on somewhere else and you have to take it down and redo it, who gets it. But you really can't use HO prophylaxis in the face of acute fractures because then the fracture won't heal. So that's the rub there,
So I
I'd have to
agree.
second that. Yeah.
So I agree with Dr. Peksima. No radiation for me. Early on, I used to do indomethacin, and later on, I realized I don't do these cases that many in a year, and I would forget putting people on indomethacin. So last 3-4 cases, nobody got anything, and here I am.
I mean, I'm especially with those very distal humerus fractures. I'm so concerned about the healing. I'd rather deal with a stiff elbow than a non-union.
Right. The only time I use it, and I don't even know if it makes a difference, is if I see, 3 or 4 weeks for the routine follow-up, if I start seeing a fair amount of HO around the elbow, then I'll give them some indomethacin if they can tolerate it, because it's pretty hard on the GI tract. I don't know if that would change the natural history of it, but that's when I would use it.
Yeah, I know. The problem is, Lou, it's like you said, by the time you see it on X-ray, typically it's at the 4 to 6 week mark where calcium has deposited and such, and by then the cat's out of the bag.
Right.
So,
Well, if there's no other questions, it's definitely past our bedtime here on the East Coast. But I just wanted to thank all of our panelists. You guys did a really great job, and we definitely learned a lot about managing these injuries in the elbow. And thank you to all the participants for coming. And like I said, log into the NYU CME site to get the actual credits from the course. And look out for our next course, which will probably be in a few months. So everyone take care. Have a good night.
Thank you, Omri.
Thank you. Thank you, everybody.